Thank you. So thank you for the opportunity to be at TCT India. All of our friends from India. It's really a pleasure for our University Hospital to be once again doing another live case. I'd like to introduce the team. I'm here working with our cardiac surgeon, Dr. Rushing. Gregory Rushing is my partner here. We have Philippe Tayeb, our fellow from Israel. We have Katie, we have Nick here, we have Brian as well, the whole Medtronic team supporting the case as well as the camera crew. We have Pedro Teixeira, who's our fellow from Brazil, that's going to present the live case of Evolut FX Plus that we're going to do today. Pedro, with you.
Good afternoon, India. We come here today from Cleveland, Ohio, to present this case of FX Plus. It's a male, 77 years old, obese, COPD, hypertension, AFib, renal disease. The NIH, it was 2, it's 2 on 5, and he has an aortic stenosis with a stroke volume of 48 in STS 4.3. His creatinine is 1.9, so clearance is 34. AFib on his AKG, you can see the curves from aortic stenosis with gradient median of 25 and TT echo and 27 ATT. He has some coronary disease, and the left main shows 40 to 50% on left main, and we did an IVOS, and it shows a median linear of 9. His access, we can see a narrow aneurysm on the right side, and so we're going to use as main access on the left. His perimeter is 7.8, so it fits a 29 FX plus valve. The angle of coronary is a little bit higher, but the sinus shows 30 millimeters of length, and the SGA 32. The coronaries are high, 15 and 19, and we're using angles of 14 and 9 here.
So I'd like to interrupt Pedro. Thank you, Pedro, for presenting the case. So as Pedro presented, this case is this patient has a very favorable anatomy for an Evolut FX plus 29. He doesn't have a lot of calcium. It's well distributed amongst the leaflets, although we predilate most of our valves here. As we talked before in many conferences there in India, we tend to predilate around 70% of our valves, but in this case, we don't believe it's necessary to do so because it's a very well distributed calcium. I wanted to highlight one aspect that Pedro showed there, that the coronaries, the takeoff of the coronaries is 150 degrees apart, and we're going to use today the latest iteration of Evolut FX, which is the Evolut FX Plus, that has bigger windows in front of the coronary ostium. These windows are located 120 degrees apart of each other, which the goal of this is obviously to facilitate the access to the coronary. So this is the same valve, the same delivery system of Evolut FX with a plus, which is the bigger windows in front of the coronary ostium that are located 120 degrees apart. Next slide. As you can see there, but in green, you can see the windows highlighted there. So it's 4 times bigger than
Can we see the slides?
the windows of Evolut FX.
We don't see the slides. We don't see the slides right now. Oh, there we go. Now we got it.
You see, go back, please, go back to so can you see that slide, Sushil?
Yeah, now we see it. Yep.
Okay, so those are the windows in green, the bigger windows that are located in front of the coronary ostium, with the goal, of course, of facilitating the access to the coronaries. Next. And for the first time, I'm going to share TCT India, sharing the first time this paper that we're working on now. As you know, we published the cannulate TAVR on jack intervention some months ago, which showed that we were able to cannulate all of the coronaries that we attempted in consecutive patients with Evolut FX. And compared with Evolut FX now, the FX Plus, we were able to cannulate the right coronary artery quicker. So the time for cannulation was reduced with this device. Next. Although there was no difference in terms of selective cannulation, but reduced time for cannulation is a very important piece of the puzzle here. And even more so because not all of the interventionists that are going to do the cannulations are very experienced in doing this. So I think it makes it much more universal and reproducible, the cannulation of the coronaries. Next. So I have just a quick example of a prior case that we have done with a CT post-TAVI. You can see that the coronary is actually 140 degrees apart next. But you can see the right coronary coming on that 3D picture. You can see the right coronary coming off of just of that big window next. And you can see also the left coronary coming from the bottom of the big window, which means that despite the coronaries are not 120 degrees apart, because the windows are so big, we have wiggle room to then have the ability to cannulate the coronaries and having them, coming off of the big window. I think that's our last slide. All right, so we're gonna move to the case here.
Can we ask a couple quick questions?
Of course, yes.
So one aspect of this is, besides the Evolut FX Plus, the gradients are low. And this sort of entity of low flow, low gradient AS, how do you reassure yourselves that it's severe, and what is the reason for low flow in this patient, and likelihood of benefit? What is the sort of the algorithm? Because I think oftentimes the AS, just for the audience here, gets unrecognized because the gradients are low and people assume it's not severe, or vice versa, that the valve area calculates low but it's not really severe. What is your algorithm in these type of patients?
Yeah, that's a good question, Sushil. So basically, we do several different things. For the paradoxical low flow, one tool that we use is the calcium score on the CT, right? The dimensions index of this patient is 0.25 as well, but we use the calcium score as our to-go tool. So every time we have a concern, and this is the calcium score, as you remember, there was a recent publication for patients with low ejection fraction that might not be applicable. And the same story for bicuspid valves. So we have to be careful because the calcium score is not universal. It's not for all patients with low gradients, right? We have a paper now, Sushil, under review on JACC imaging that we're trying to reconcile the 4 imaging modalities. It's the invasive gradient, CT calcium score, echo, and MRI. So we did MRI in a lot of patients prior to TAVI. And one very important tool is the valve area by the short axis on the MRI. That also helps a lot, and the paper is going to show it's a very good tool for us to determine if the aortic stenosis is severe. So we use basically these are the tools that we use, Sushil.
What about the beta stress echo? What did you ask?
The EF is normal here, so there's not a role for Mean stress.
EF is normal, is it?
Yeah.
Sushil, do you do anything different at Columbia?
No, same thing. It's sort of the visual appearance, calcium score, DVI. And in this person, if you look for reasons for low flow, and here it's maybe the AFib, but we're also seeing a lot of amyloid, and if the tissue Doppler on the echo is low, we look for amyloid and other reasons. How about the rest of the panel? Any thought?
And that's why, Sushil, the amyloid is, you're right. And in fact, of course, having the MRI is a great tool because we can also, look for amyloid on that. Obviously, I understand that the cost of the MRI is somehow prohibitive to apply for everybody, but we have been using this tool in situations that are kind of questionable, and this paper is going to show that it's a very good tool and very reliable.
So, Guy, this is Ramesh Daggubati. I completely agree with you that this paradoxical low flow, low gradient aortic stenosis patients still do much better if their calcium score is higher than as compared to lower in terms of their outcomes or improvement in KCCQ scores and all of that. So, but MRI is a good tool, and I wanted to ask you, how frequently are you testing them for amyloid?
Not very frequently, Ramesh. These patients that I mentioned to you that we were doing MRI consecutively pre-TAVI, we don't do them anymore, right? This was just a part of a study that we were doing. But we don't frequently do, unless we have a high suspicion of amyloid, then obviously we're going to use the MRI, or if the calcium score is not that high, and then we have a question, the patient is very symptomatic, right? Then in this situation, then we would use the MRI, but we don't routinely test for amyloid. Do you guys do anything different? Do you test routinely, Ramesh?
Yeah, we are trying to promote that. We have a heart failure team who we are trying to promote that actually amyloid in almost all patients with concentric LVH plus aortic stenosis, all of them routinely trying to get a P2P scan or at least light chains and we are checking that.
We did a study.
That's
with,
a nice suggestion, Ramesh. I think we're going to start doing this here too. Maybe we can do something together, huh?
Yeah.
Some project, huh?
So
That would be good.
Unless there are any other questions, if you want to keep moving forward, we don't want to hold you up, but just it's
Yes.
interesting.
So what we have here, just to show you guys the setup, basically what we have. So we have a 14 French centron sheet on the left. As Pedro showed, we have an aneurysm on the right iliac, so we wanted to avoid, going on the right. So we still have the 6 French on the right, and then we have the 14 French centron sheet on the left. We're going to use the Safari Extra support wire. The Safari Extra support is similar to the Lunderquist. The stiffness of this wire is similar to the Lunderquist, and we usually use the extra small curve for every patient. We don't customize. We always use this extra small curve for every patient. As I mentioned, we're not going to pre-do. We already checked the valve under fluoroscopy, so we're good to go here. And in the end of the procedure, we're going to cannulate the coronaries to show you guys the cannulation of the coronary with Evolut FX Plus. So Greg is going to now put the wire in the LV. Guys, let's get another ACT. Give me an ACT syringe here, because we took an ACT, it was 351.
Do you pace off the wire, or do you put a separate pacer?
So Sushil, that's a very good question. We have a jugular pacer here. Why we do not pace off the wire? Because for several reasons. And I'm gonna justify the reasons. Basically because number one, we like to go in the very end of the procedure. We're not gonna deploy the valve, you guys are gonna see. I like to pace for the final deployment of the valve, right? And for that, I like to pull the wire back. I pull the wire back inside the nose cone. So if I have to pull the wire back and pace, it's incompatible. I cannot pace over the wire. We don't use the Savvy wire here. Oh, come on. Got it? Yep. The Savvy wire. Don't like that. Yes, that's why. We don't use the Savvy wire because the Savvy wire is too expensive, and I really don't see too much value on that, honestly, right? And the risk of complication with the pacemaker with a balloon tip pacemaker is extremely low, right? And we put all of our we put all of our pacers via the jugular vein because patients go, if they have to go to the floor with a pacer in, which is unlikely, but when it happens, right? If they have to go to the floor with the pacer in, then it's in the jugular vein, they can mobilize earlier. So we don't pace with the wire because of that. I don't see really like significant value of doing it because it's going to impair me to, pace in the end when I'm gonna finally deploy the valve because I like to pull the wire. So we don't do it.
That makes sense.
What do you guys do? Do you pace over the wire all the time, Sushil?
We're starting to try it occasionally. We're not doing it routinely. And someone that has a pre-existing pacer or something, and we're doing a Sapien, we've been doing it because they already have a pacer. So we're doing it for Sapiens intermittently right now. For Evoluts, we tend to use the wire for positioning and also tend to pull it back at deployment, final deployment. So that reason as well, we have not been.
Pretty much the same rationale. I got it. Yeah. So guys, another thing we're doing, here, we usually use the inline sheet, right? The exchange of the sheet to the 14 and going with the inline. Some people feel uncomfortable with this part of the procedure, which I don't. I think it's routinely fluid. So we're keeping the flush port 3 o'clock. We can give 1 and 50 of sedation, please.
Very smooth.
So I'm keeping the flush port at 3 o'clock. Per our data with Evolut FX Plus, with Evolut FX, I should say, if we keep the flush port at 3 o'clock, 97% of the time we're gonna have commissural alignment, which is greater than Evolut Pro. Can you adjust my goggles here, please? They fell off me.
I have to say.
So which is greater than Evolut Pro. So we're gonna keep the flush port at 3 o'clock. Then we're gonna confirm the commissural alignment which again, in this patient is extremely important because he does have coronary disease, has a patent stent in the LED, and he has some disease in the left main, not severe per the IVUS. Sorry guys, I'm just fixing my goggles here. All right, that's good, thank you. All right, so we're gonna go LAO to cross the arch.
What is the advantage of this plus? Only the hole is bigger.
For the coronary access.
What is the question?
No, there was a question of what is the FX plus? We were just talking about the coronary access windows.
Let's go.
Ready? Coming up.
I'm gonna cross the arch now, always in LAO, obviously. Keeping the flush port at 3 o'clock.
Very smooth.
Perfect.
Stop there.
So the FX allows us, and again, the FX and the FX Plus, exactly the same delivery system, exactly the same thing, just a valve that has bigger cells.
So
it crosses the arches very, very smoothly, even like more complex anatomies. What is the
yeah, I mean, so in India, both Evolut R and Pro are available. There's a cost difference, so there's a lot of Evolut R still used here. So that delivery system is obviously different with the two spines, and the behavior of the valve deployment is different. So it is worth sort of mentioning that this is not like the R.
All right, guys. So we switch our camera to cusp overlap. In LAO, we could see the head marker in the outer curvature of the aorta. Now in cusp overlap, we should see the head marker either to the left or facing us. And then the last check is gonna be the golden markers, okay? So we're gonna go now. 340 ACT check.
So if your hat marker isn't favorable and you don't think it's gonna be commissural alignment, do you pull back into the descending thoracic aorta and rotate?
That depends on the patient I have on the table, Sushil. In this case, I would because he has coronary disease, right? So then I would do it.
Okay.
Even if I am a step ahead, right? If I am at 80% and I see the golden markers are not properly positioned, I would recapture and bring down to the descending. Because in this case, since he has coronary disease, if it's like a 95-year-old patient with no coronary disease, then I would just let go. But yes, in this case, I would, if I had to. Okay, buff there. So, we're gonna reposition the pixel tangle there. Another aspect, you're gonna see the difference, as Sushil was mentioning, you guys have Evolut Pro or R, or Pro Plus or R there. We're gonna start, buff there, there we go. You're not
In the right.
yeah. So, there you go, buff. Perfect. You see, Greg is already an interventionalist. He's a percutaneous surgeon. Huh? Go hard. So look at what Greg's doing. So we're gonna start here. As you can see, we're not doing anything wrong because with Evolut Pro and Evolut R, remember, you start halfway through the pigtail. The Evolut FX, because it's a more stable deployment, we're gonna start closer to the bottom of the pigtail. Almost in the bottom, so that's where we're gonna start. I'm gonna start rotating here fast, obviously, right? Because the valve is completely covered. Don't move, sir, stay still, shallow breaths, please. Pull, shallow breaths, stay still. Micro puff.
What is your goal?
So just so you guys know, we didn't take any pictures so far, 0 pictures. We didn't take an orthogram, no push. So we have not taken any pictures.
What is
So we're
your
going very slow.
what is your
right?
goal depth here? You want it like 3 below or like at 0 on the?
No. Sushil, we're gonna aim it like at 0, as you know, right? If we go too high, we may pay a price, right?
Yeah.
Higher implants for, if we need, not this case, but in general, for TAV in TAV, for example. So 3 is my kind of go-to. That's my goal here. 3, 4, I'm happy. Puff, micro puff, good. So are you guys happy so far?
Yeah, I mean, I think those dots
Okay,
on the
looks
bottom
good,
was one of
right?
the greatest
3 millimeters.
innovations.
So as you guys
Those
know,
dots.
right? 3 millimeters. The golden markers are positioned at 3 millimeters. Pacemaker on, 140. Good. 150, puff. 160. Pacers. Our pacer is not helping us too much, puff. Don't move, sir. Stay still, please. Puff.
Down, down, down. Nice, nice.
Seen it? Seen it. Pacemaker at 120, inject. All right, going LAO. Fluoro. All right, seen it? Inject. All right, panel, happiness or frustration?
It looks good.
You guys have, so basically what we did, right? We went RAO for the implant for cusp overlap. Then we moved the LAO to make sure we capture the left, right? So we capture everything. Now we're gonna, again, that's of the procedure.
So can you
Greg
show us
in first position is gonna, go ahead.
Can you show us that RAO cine again, just to go over it for the audience real quick?
RAO picture. I'll show you, one sec. Here.
Yeah, it looked like
There you
2
go.
millimeters on the RAO.
Yeah, so,
Maybe
yeah,
one.
and I think here again, you look, because this is the sort of the cusp overlap, but you have the 2 dots on the left side, it looks like you have commissural alignment, right?
That is correct, Sushil.
Because
in fact,
the 2 dots on the bottom are on the one side, so that's a good check for you right here, right?
yeah, indeed, Sushil, and because we wanted to confirm that Medtronic was actually telling us the truth, right? That actually corresponds to commercial alignment. We did a study with CT post-TAVI that indeed when you have the position of the Golder markers that way, in 97% of the patients you do have either mild misalignment or complete alignment, so that you can rely on those Golder markers to understand if you have commercial alignment. That's a very good point. Fluoro, please. So now we're gonna deploy, and the deployment, I'm gonna pull the wire all the way inside the nose cone to centralize the nose cone. If you look at the screen there, the nose cone is centralized. I put the wire all the way in, barely inside, not all the way back, because the connection between the catheter and the nose cone is very flimsy. So I pulled all the way just inside the nose cone. Greg is gonna do mild forward tension, and we want to have the systolic blood pressure around like 110. So pacemaker at 140, please. And I'm gonna go very slow. So I'm going very, very slow here to let the nitinol progressively expand.
I mean, you can wait at
Greg
this
is doing
position as long as
a
you
mild
want.
forward tension. And I'm going extremely slow to let the nitinol expand very, very progressively, so we have a stable deployment, right? That's the goal here. So you see how slow I'm going. This is how we deploy all of our valves, very slow. Yeah, pacemaker 150. So I'm letting now the valve expand. I'm not doing anything, I'm just letting the valve expand progressively. At this point, Greg is not pushing, he's just neutral. He's just letting things happen. Going very slow here. As you can see, the top of the valve comes out progressively. Don't move, sir, please. Hands still, don't move. As you can see, guys, our patient is, of course, awake. Very mild sedation, but awake. We're talking to him. Are you okay there, Paul? Is he okay? All right, good. All right.
Still attached.
Still connected? Disconnected?
Ready? Coming back.
Careful. Spacer off. As you can see, I do not keep the wire in the LV, right? We pull the wire back, and we're gonna pull the pigtail. Also, some people have this concern of the pigtail, pull the pigtail prior to, no, nothing, you don't need it. So pigtail never pulls the valve out. If after you're done, just pull the pigtail back. We're gonna do echo now. Echo,
Another way to go.
and hemodynamics. So echo team is here. I hope we did a good job. Greg, in the meantime, is doing his fast track, trying to cross the valve before the echo shows up here. But the echo is here, so we don't have more time. You got it. You see? I told you guys, he's a percutaneous surgeon. He is better than an interventionalist, man. We worked together for so long. This is something in the United States, right, that we have, strong surgical partners. So it's very collegiate. We worked very well together, and this is really something that we appreciate.
It's really a great team.
Right, Greg? Huh?
Absolutely.
All right, 00, please. In the meantime, Echo, you're good
So
to go.
you,
1 second.
you
Let me
saw
put
as
the
the
robot
valve
out of-
finally released, it did cant, and that's in that anterior posterior, and typically it will drop. So sometimes we always worry that we're too high, and you'll get this motion. And that's what's a little bit unpredictable sometimes. But I think he showed as long as you're anchored on the cusp overlap on the non, and you verify it by going LAO to the left. In general, we try to keep it at 3.
You saw him
So
pushing the
I have one
pigtail-
comment to make about the
You saw
canting
him
and
pushing
the
the
movement
pigtail into
issue.
the valve. Is it the way you should do it?
You can do it with that or use a J-wire, either way.
One second. In terms of the canting, Sushil, the comment of the canting, I don't see the echo on the screen.
We can see the echo.
Can you see the echo?
Yeah.
we can.
All right, awesome. You see it, right?
Yes.
Beautiful, excellent. So Sushil, just a comment in terms of, so we go very slow to deploy the valve. One story is you have either ventricular or aortic movement or significant movement of the valve, right? The other one is the canting. The canting is normal to happen, and that's going to depend obviously, right, on the distribution of calcium and how much of force. That canting, sometimes even when we're implanting balloon expandable valve, Sapien, or my valve I've never done, but Sapien, right? Sometimes you align the valve precise, and when you inflate, you see that the valve comes with parallax of the interaction between the valve and the native anatomy of the patient, right? I think what is important for us is the fact that the valve actually doesn't move. This movement, I don't really kind of buy that story, because as long as you deploy very slowly, which we did, we can take this one out and put this as superplan. As long as we deploy slowly, I would say that 99% of the cases, we have a very, very stable position of the valve. Even the case that we implant, we are too high for whatever reason, right? So it is important, crucial, the 4 elements for the deployment: pulling the wire, gentle forward tension from the first operator, very slow deployment, and pacing. If you fulfill these 4 criteria, you're going to be fine. Very rarely the valve is going to move, and therefore you're going to have a very stable deployment in the end. So that's, I'm sorry, I could not see the echo while I was talking to the team. How are you looking, the echo? Looking good?
Echo looks very good. There are no PVR.
Okay.
I think gradient is, I think, what, 5-4?
Excellent. And we're going to do now have invasive. Can we zero the blood pressures, please, guys? We are inside the ventricle. We have the pigtail through, so if you have a little central eye, it's normal. Okay, the pigtail is through the valve, just so you guys know. Let's see there. All right, nice job, huh? All right. How much time do you still have, Sushil?
Oh, we have plenty of time. So
Plenty of time, good. Because what I'm gonna do now, we're gonna close the left. That's what we do routinely, so we don't do anything different for live case. We're gonna close the left very briefly, and I'm gonna cannulate the right and the left coronary, okay?
okay.
Because I don't like to leave the large bore on the other side while I'm cannulating the cords, right? So that's all. We're gonna be briefly in the closure. Since we're talking about closure, how about we discuss this? I think one of the things that's being people talk a lot about is, oh, we only use one proglide for the 14 French sheath. What do you do, Sushil, Ramesh? What do you guys do? Do you do only one proglide, 2 proglides, and why?
So I switched to 1 ProGlide, and if at all there is a need, after giving protamine, I'll go for an angio-seal. Otherwise, actually 1 ProGlide and manual pressure is working quite well for us.
How about Columbia,
Yeah,
Sushil?
same thing. I mean, we're using 1 ProGlide, it doesn't hold, then we add a plug on top of it.
I still do too. I mean, unless it's depending on the size of the vessel, but I think that part of it is the sheets in and out can disrupt. In an obese patient, sometimes disrupt the knots, and it's not that. It's just there's a safety net of the second, but because I don't see the issue of pinching in the artery, and I haven't been concerned about it, but maybe I should be.
If you allow me to say, I agree 100% with Sushil, because we use 2 proglides because it's a more consistent hemostasis, right? As you can see, guys, there, just before we talk about this, Hemodynamics looks great, right? So EDP,
Can we
the
make them
EDP
big? Can we
is-
make the hemodynamics big? We can't. It's really small right now.
Oh,
Can
okay,
you
sorry,
make the
one second. Let me show you. Can you see hemodynamics now?
Yeah.
Yeah. Now we see it.
All right, beautiful. Let me take this pigtail out of the way here. All right, pulling back.
So no peak-to-peak gradients on bike.
Yeah, no, and the EDP, so it's important, the hemodynamics, when we do only TTE, let's go close the ground, go to the left side there, please. When we do TTE, we don't do TE, we always rely a lot on the hemodynamics because as you know, right, the TTE may miss PVL. So therefore, the hemodynamics is very important for us because we're gonna rely obviously on the echo and the hemodynamics. As you notice, we didn't do aortogram, and we almost never do. Almost. Why? Because the aortogram does not add too much additional information. In this case, trivial PVL, the EDP is the same or lower. There's no need to do an aortogram. Why am I going to inject 20 cc's more of contrast just to make me feel better? There's no need for it. And remember, his kidney function is not pristine, so we want to avoid that.
Yeah, I completely agree with you. I don't think that there should be a routine anything in patients like these. I mean, if the diastolic pressures are good, above 60, I don't even worry about anything else, not even post-dilating anymore.
And another thing you can see, we are closing the groin here with, we didn't put the sheet back in, right? Because we removed the wire, we don't have to do that. Buried there, right? Is it buried? Okay, coming out to delivery system. Just 1 second, guys. Let me just focus here 1 second, okay?
Yeah, sure.
Okay, I got it.
I mean, I think meanwhile, Sushil, do you give protamine regularly?
We do, let go. We do, every patient. However, we're not giving here because I'm gonna cannulate the coronary, so I'm gonna give the protamine after, okay?
After, yeah. So the only time actually, it was a very funny situation where we were doing under TEE and the sapien valve was implanted, ready to get out everything and gave protamine. And the TE person was just still showing, looking at the valve. And suddenly there was a clot on the valve.
Oh yeah?
There was a clot on the sapien valve. So I went back with the 8 French guide and actually sucked it out. Luckily it came out. I don't know how it came out. Yeah,
An
so
acute clot.
Yeah,
on
we
the valve?
give protamine for everybody.
I know.
In the end.
Yeah, I pretty routinely give it as. I mean, occasionally don't, but more often than not give it.
Yeah, so
Just because it's a little bit of ooze all the
I
time.
started like underdosing, like 30 of protamine.
Yeah, we give half dose. That's what
Yeah,
we
half
give.
dose,
We
yeah.
give half dose. Yeah.
So guys, just one comment I want to show you guys here. So there is still some minimum bleeding, but as we talked about, right? This should be okay for us to do manual compression. So we're gonna remove the wire. We're gonna lock the ProGlide. We only lock after we take the wire out. And then we're gonna finish with manual compression. Okay, so we don't need to put an additional closure device here. The stick is mid-femoral head, so it's a good stick. So we're gonna finish with manual compression. Wire out. Let me go in. So I'm gonna close the whole of the wire one more time and lock the ProGlide, always in a coaxial fashion here. So Pedro is gonna do. Let me go. Pedro's gonna do the
Manual compression.
okay, hold. So Pedro's gonna hold the groin while we cannulate the course. All right, so let's cannulate the course now. All right. So you guys know, I'm gonna describe the design of our study. I need 5 volume and flow there, please. So the design of the cannulate TAVR, and we're doing this the same with Evolut FX Plus, is basically we cannulate, we go with the JL 3.5 and a JR4 for every patient. Meaning, I do not use the information from the CT to choose my catheter because I did not want to be a biased study, right? So I'm getting, give me a flush, please. Thank you. I didn't want to use the CT information to bias me, right? So basically what I do, we go with the 3.5 JL, and I'm allowed, thank you, I'm allowed to switch if I don't think that's appropriate catheter. Okay, so going up here. In addition, I want to say something else here. I believe you guys have seen like online, you know, people love to put things on social media and stuff, right? So I need to say this, sorry. So there's no drama here to cannulate the coronary. Go LAO, so you have to go LAO, which I'm doing, right? We're gonna go LAO. We don't try to align the, you know, the dots, nothing. Go LAO, and we're gonna go, timer please. We're gonna start timing now that the catheter is in the arch, right? So, Mag one up.
So first, he's making sure the wire's inside the core valve frame.
That is a very, very important indeed,
Right.
yes.
And then, you know, he's LAO like we normally do with cannulating the left coronary, and trying to find the large hole. And this catheter may be a little small, but
That is correct, Sushil, maybe a little too small. But I have to follow the protocol of the study, that's why I went, I may be
You're
through.
in.
he went through, yeah.
All right.
I mean, oftentimes, you know, it is the JL35, especially with the Evoluts, because you've sort of narrowed the route with the frame, and so you don't have, the 4 is too long for back wall support, so it ends up being a 3.5. But this is a big valve, right? This is a 34?
Yeah.
Was it 34 or 29?
Again. All right, guys, we're there. All right, so cannulated left coronary. Of course, this is what we call in our study. In our study, give me the stiff part. So now I'm gonna take the JL out. I use the stiff part of the O35 wire. I want you to show you this movement. Because if you do this, of course, I'm not gonna put it out of the catheter, but when you push the stiff part, look at what's gonna happen with the catheter. It's very, very elegant. You remove without trouble, like that. So then I go with the other one. And remember, we took this picture. We used the same definition for coronary cannulation of the Tarantini and Barbanti's paper, which is this. So we took this picture now. We were in front of the ostium of the coronary. This was not a selective picture, but per the definition of our study, we would take whatever happens first. And this can be considered a non-selective because we're right in front of the ostium, okay? So this is important, right? We took both definitions as non-selective or selective, and whatever happens first, we take it. Now we're gonna go with the JR. In our initial study for Evolut FX, we were able to cannulate the right coronary 100% with the JR4 and 80% with the JL 3.5, the rest JL4. Okay, timer. Timer up. Good. All right, so now same process with the JR. So he has also a stent in the RCA. Another, once again, re-emphasizing the importance of having access to the coronary. This happens, these are actually something that happens quite often. Depends on the anatomy of the aorta. When I'm rotating the JR catheter, sometimes you see that the catheter goes to the LV. Not infrequent to see. In this case, what I tend to do, I tend to start, you see, I just try to rotate, the catheter already falls down. So when this happens, I try to start a little higher than I would normally do.
So by aligning the commissural dots, you could open up the window as well. Do you ever do that to sort of help you, or is that?
I don't, Sushil. I do not open, because I got so used, to be honest with you, I got so used to cannulating with the Evolut FX that I don't know that I see like a huge value on it. Puff. Right, pressure is good. Puff. All right, we're there. Timer off. Okay, so both coronaries cannulated in seconds or minutes. The right CA was very quick, so was the left. Again, this is
how do you...
We do not.
How do you
Go ahead.
use this information? So do you put it in the report? Like, for example, if this patient came back for a coronary angiogram, probably a JL4 would be a better catheter, right? Because you were a little bit short with that, it seemed like. Would you put that in the report so it's available if the guy came in the middle of the night? Is this something that we should be considering so when people do come back, or that we understand what the anatomy is to cannulate?
Sushil, I think you were having access to my IRB proposal. I think so. I think you have some spies here in the university hospitals. No, I'm just joking, Sushil, because this is exactly how we were able to sell the concept of the study to our IRB, meaning, oh yeah, we're doing this, there is a purpose of doing this, right? And the main purpose is exactly that one, that we have documented that 3.5 JL, JR4, we were able to cannulate the coronaries, and if in the middle of the night this is required, there is at least some piece of information to whomever is gonna do that, right? So yes, you're right, and that's the way we're able to basically make it happen. Okay guys, 5-0 of protamine, please. So we're all done here.
So I guess the question is, and one of the challenges is that if they come to your center with a STEMI, you understand, and you've done with a lot of valves. And here in India, more valves coming in, but the STEMI centers are everywhere. And people present with a STEMI, and they have a valve in place. How do we educate? Like, what do we do? Like, in the middle of the night, how is someone going to handle it? What are the resources? And are the companies providing resources and some training? Like, if somebody comes in, can somebody call Medtronic and say, how do I do this? Or maybe some comments here from.
Yeah, so sure, that's a very important
I know a
aspect.
person, cardiologist, who has never done a TAVI. He had a patient with acute MI who had already a TAVI done. So we took it and just did it as he had acute MI, inflow MI, cannulated and did it. I saw the picture. So his beginner's luck could be, but there is no definite way of telling how to do it, but it's so infrequent. We don't have any guideline on this. So people try in the same way like they do it acute MI, and it goes trial and error method.
So Sushil, that's a very important. That's a very important comment.
Induction teaching center and others also is good
Yes.
idea.
Yeah, I mean,
So
I think
Sushil,
Sorry, go ahead, Guy.
can I just make a comment? I just would like to make a comment on your question. So this is a conversation that of course I've had with Medtronic, right? That our job is we're actually building the blocks here. So starting, right? To start, we need to show that this is doable, right? We can cannulate the coronaries, it's feasible. This is one story. The other one, so which we did, right? Then the next story, can we give him like 50 of fentanyl, please? Thank you. So the other story, Sushil, is to make it reproducible, because one story is that I cannulated 99% of the coronaries here, so it's a single operator procedure, right? So we need to make sure that this is actually reproducible, right? Which is now what we're doing. We have another center in Japan, my friend and colleague Yohei Ono, he's cannulating the coronaries via radial. So we have radial and transfemoral. So we have to be, it needs to be doable, needs to be reproducible, right? That's what you're doing. And the next step, Sushil, is exactly what you said, which is educating our colleagues, right? Because people do have to feel comfortable, right? Having a STEMI in the middle of the night and knowing what to do, right? And honestly, I think that Evolut FX Plus with a bigger window is already kind of emotionally, I don't know if that's the right word, but when you go in, or whomever is the interventionist that is not using to doing this, he's gonna feel more comfortable. I have a bigger window, 4 times bigger than the other valves, I'm gonna make it, right? And I think this is our job. We have to do that, and we have to engage the company, and we have to engage all of the stakeholders necessary for that. Because as you know, right, people talk about a lot the fact that, patients who have the incidence of the requirement, the need for intervention post-TAVI is low. But those data come from patients that are older, moderate or high risk patients. As we know, treating lower risk patients, we're gonna need to have more access to the coronaries. And not only that, right? when we talk about TAV in TAV, it's another discussion here. That's why it's our job, and we were talking about the depth of the implantation, right? We were amongst the centers that were all, happy and implanting valves high, but we know when the pacemaker, high pacemaker rates was a big issue, right? Today, however, we try to customize in a different way. We try to implant actually the valve like 3, 4, sometimes, even deeper. Depends, right? Because we want to make sure that the patient can get a TAV in TAV in the future. That's going to be based on the amount of oversizing, the anatomy of the patient. It's going to be based on, prior conduction system, multiple things. I say that today we are in the era of the customized TAVI, right? We have to customize for that patient. What are we going to do? Are we going to recapture if we have misalignment of the commissure? Are we going to implant? What is the depth? So we need to take all of these factors into account to be able to deliver the best to our patients. That's our philosophy here, and I think that's what we have to try to do.
That's great. It's interesting you talk about, lifetime management issues in valve, and, with Evolut FX Plus, potentially you could do another Evolut even, because you could cut the leaflets and maybe the windows open up, maybe there's less metal in front of the coronary. Eberhard, you've been here from the beginning, and
Yeah, I think, Guilherme, this is Eberhard. Congratulations. I've not seen the whole procedure, but this was excellent. And obviously, the result is perfect. As far as the coronaries are concerned, I think what is important that you're patient. In order to do that, you can't really rush in. Usually, I don't take the GR4. You take the GR 3.5 to get the bend a little bit more, but that's obviously personal preference. On the left side also, so usually I don't take the same that I'm using to intubate the coronaries with. I take one size down, but it's beautifully done, Guilherme. Congratulations from my side here. Perfect.
Eberhard, thank you for your comments. Coming from you is always an honor for us, right?
I just came
really
in when you deployed the valve, and it always makes me really happy that somebody is not rushing it. And what you just said, first of all, the depth was perfect, the cusp overlap, and then you were patient releasing the valve. That was the intent when we started this, and you showed this with your team beautifully. And look at the result; it's just perfect. Congratulations again. Excellent.
Thank you very much. Thank you, Eberhard. Thank you, Sushil. Thank you, Ramesh, all of the friends from India. I'm looking forward to meeting you guys soon in September. So if you have any other questions, any other comments, Sushil, Ramesh, all of the other colleagues, I don't know who else is in the panel there.
Well, no, thank you so much. I know, I don't know what time you had to get started. I know at our institution to start live case at 7:30 for a TAVR would have been very difficult. So I appreciate your team. I don't know if you had to come in earlier, or that's your normal start time, but appreciate everybody coming in early and for a wonderful demonstration. So thank you to you and your team.
Thank you, guys. Really nice. We're very honored to be part of this, and looking forward to next year. Thank you. Bye-bye.
Thanks.